Hello everyone, so today we'll be doing a case, interactive case. This is from the University of Minnesota, and it's a case on confusion and black urine. So let's start. Click the location for more information. This patient is 31-year-old male from Tanzania. Initial complaint, confusion. So let's go to the history and see what's going on. A 31-year-old Tanzanian male presenting to district hospital with confusion for 3 days. Family notes that he has had a high fever for about 2 to 3 days. This morning, he didn't know where he was or his name. He was talking nonsensically. Upon arrival to the hospital ward, he has a tonic-clonic convulsion seen by nursing that involve all 4 extremities with urinary incontinence and tongue biting. So it's a generalized tonic-clonic seizure here. So it's confusion for 3 days, fever for 2 to 3 days, and a generalized tonic-clonic seizure just now. Uh-oh. Can I go back? Yeah, misclick. Review of systems. So review of system, generally there's fever and shaking chills. Visual changes, no blurry vision or loss of vision, no red or yellow eyes noted by the family. Head and neck, no neck stiffness or pain, no ear or facial pain. Pulmonary, breathing fast with some shortness of breath, no cough. Cardiovascular, no chest pain or topnia palpitations or paroxysmal nocturnal dyspnea. GI, had 1 episode of vomiting prior to arriving to hospital, no diarrhea, jaundice, or blood in stools, has generalized abdominal pain that is not localizable. GU, dark-colored urine without dysuria, 1 episode of urinary incontinence with the convulsion, no penile or scrotal lesions. Heme or oncological system, no known easy bruising. Neurological system, please refer to history of presenting complaint, which was the confusion and seizures. Muscular skeletal, generalized body aches, malaise, no joint pain. Generalized body aches, malaise, no joint pain. Skin or hair, no rashes or skin lesions. Is his house, is it? So far there's only shortness of breath, dark color urine, some neurological signs. Right. Oh, yeah. Has generalized abdominal pain. Vomited once before arriving at hospital. Okay. Past medical history. Please select from the following topics to learn about the patient's past history. Past medical history. No past medical history, no history of surgeries, not taking any medications, no smoking history. That's good. No allergies, family history. Father passed from old age. Mother alive and without known medical history. Social history. Recently traveled to coast of Tanzania. Lives in Masai village. Has got many cows and goats there. Was caring for farm animals. No military service. Married with 2 children. Okay. Next, let's check what is your differential diagnosis. 3 days fever, 3 days confusion, seizure. What could be causing? Encephalitis, meningitis. What else can cause seizures? Confusion, abdominal pain. So there's abdominal pain. There's vomiting prior. Oh, he could have DKA as well. Although there's no family history of diabetes. What else? Did he have diarrhea? No diarrhea, right? What else did he have? Oh, dark urine. What's causing the dark urine? Something more. What can cause dark urine? Malaria. Malaria can cause this as well. It's in a rural area. We need to think about other stuff. Dengue. Dengue can cause encephalitis as well. Malaria, dengue, Zika, chikungunya. I don't know how to spell this. Chicken, is it? Never mind. Not important. This comes as a set. I think it's differential. Most likely malaria given the dark urine. Could it be leptospirosis as well? Was leptospirosis cause encephalitis though? Yes. Okay, next. Which of the following diagnoses are most likely to explain the patient's symptoms? Addison's, you can have confusion as well. However, it doesn't explain the dark urine. And usually have hypotension, I think. Malaria is the most likely. Celiac disease. It doesn't usually present like this. It usually presents with long-term diarrhea, vomiting, maybe even weight loss if it gone for a long time after eating gluten stuff. Yellow fever, I don't know what this is. Need to learn about it. Whipple's disease. What is Whipple's disease? I should make a note of what I want to study later. So okay. Correct. Malaria is the most likely. Physical exam. Oh, there's a scar here. Click to play. What's going on here? There seems to be some deep breathing. There's a scar in the right upper quadrant. Some operation was done prior. Is the deep breathing related to Kussmaul's breathing? Or is Kussmaul's breathing?
This little guy come in with a pH of like 6.9. He's actually got a little bit of a dental, probably a dental abscess. It's kind of keeping his smell is sort of odor to it. So he's getting his getting a little fluid bolus at 20 per kilo, and then we're gonna.
Kussmaul's breathing is a deep and labored breathing pattern, often associated with severe metabolic acidosis, particularly DKA, but also kidney failure. It is a form of hyperventilation, which is any breathing pattern that reduces carbon dioxide in the blood due to increased rate or depth of respiration. In metabolic acidosis, breathing is first rapid and shallow, but as acidosis worsens, breathing gradually becomes deep, labored, and gasping. It's this later type of breathing pattern that is referred to as Kussmaul's breathing. Okay. So now we wanted to know what is yellow fever. Yellow fever is a viral disease of typically short duration. In most cases, symptoms include fever, chills, loss of appetite, nausea, muscle pains, particularly in the back, and headaches. Symptoms typically improve within 5 days. In about 15% of people, within a day of improving, the fever comes back. Abdominal pain occurs and liver damage begins, causing yellow skin. If this occurs, the risk of bleeding and kidney problem is increased. The disease is caused by yellow fever virus and is spread by the bite of an infected female mosquito. It infects only humans, other primates, and several types of mosquitoes. In cities, it spreads primarily by Aedes aegypti, a type of mosquitoes found throughout the tropics and subtropics. The virus is an RNA virus to the genus Flavivirus. The disease may be difficult to tell apart from other illnesses, especially in the early stages. To confirm a suspected case, blood sample testing with polymerase chain reaction is required. A safe and effective vaccine against yellow fever exists, and some countries require vaccinations for travelers. Other efforts to prevent infection include reducing the population of the transmitting mosquitoes. In areas where yellow fever is common, early diagnosis of cases and immunization of large parts of the population are important to prevent outbreaks. Once a person is infected, management is symptomatic. No specific measures are effective against the virus. Death occurs in about half of those who get severe disease. In 2013, yellow fever resulted in about 127,000 severe infections and 45,000 deaths worldwide, with nearly 90% of these occurring in African nations. Nearly 1 billion people live in the area of the world where the disease is common. It is common in tropical areas of the continents of South America and Africa, but not in Asia. Since in the 1980s, the number of cases of yellow fever has been increasing. This is believed to be due to fewer people being immune, more people living in cities, more people moving frequently, and changing climate increases the habitats for mosquitoes. Global warming actually increases the population of mosquitoes because it decreases their life cycle. They turn into mosquitoes faster. Their turnover time is faster because of the higher temperature. The disease originated in Africa and spread to South America in the 17th century with the Spanish and Portuguese importation of enslaved Africans from sub-Saharan Africa. Since the 17th century, several major outbreaks of the disease have occurred in the Americas, Africa, and Europe. In the 18th and 19th centuries, yellow fever was considered one of the most dangerous infectious diseases. Numerous epidemics swept through major cities in the US and other parts of the world. So it's another mosquito-borne virus, like dengue virus. It's spread by Aedes aegypti mosquitoes. That's what yellow fever is. What's Whipple's disease? There's Whipple's procedure. It's a type of surgery. Thing is to remove the head of pancreas. Yeah. Whipple's procedure is removing head of pancreas, duodenum, and also the gallbladder, and joining it up again, re-anastomosing. But now we're talking about Whipple's disease. It is not very helpful to name diseases after yourself, so don't do that. Okay, Whipple's disease. Mayo Clinic, Wikipedia. Whipple's disease is a rare systemic infectious disease caused by bacterium Trophorima whipplei, first described by George Hoyt Whipple and commonly considered as a gastrointestinal disorder. Whipple's disease primarily causes malabsorption, but may affect any part of the human body, including the heart, brain, joints, skin, lungs, and eyes. Weight loss, diarrhea, joint pain, and arthritis are common presenting symptoms, but the presentation can be highly variable in certain individuals, and about 15% of patients do not have the standard signs and symptoms. Whipple's disease is significantly more common in men, with 87% of patients diagnosed being male. When recognized and treated, Whipple's disease can usually be cured with long-term antibiotic therapy, but if the disease is left undiagnosed or untreated, it can ultimately be fatal. It's caused by a bacteria. It causes malabsorption, but it may affect other parts of the body as well. Yeah. Signs and symptoms. The most common symptoms are diarrhea, abdominal pain, weight loss, and joint pains. The joint pains may be due to migratory, non-deforming arthritis, which may occur many years before any digestive tract symptoms develop. Actinomycetes mechanism. This is a distant relative of Mycobacterium avium intracellular and Mycobacterium paratuberculosis, explaining in part why Whipple's disease is similar to the disease caused by these bacteria. The disease is common in farmers and those exposed to soil and animals, suggesting that the infection is acquired before the source from these sources. All right. Lots of diseases that I don't know about. All right, back to the case. We have physical examination. General appearance initially confused and speaking nonsensically, then obtunded, followed by convulsion. Vital signs: blood pressure is normal, heart rate is raised, respiratory is very raised. SpO2 on room air is very low. You want to give him oxygen straight away. Skin and lymph nodes. Skin and lymph nodes, no lymphadenopathy, no rash. Okay, head, eyes, ears, nose, atraumatic, normal extraocular movements, pupils equal and reactive, dry mucous membranes, is dehydrated. Neck, no JVP, supple neck. What does supple mean? Supple, bending and moving easily, gracefully. Should be normal, I guess. Chest and lungs. Deep and rapid breathing. So there's Kussmaul's breathing, I guess. Rales present in right lower lung. So there's some crackles. Rales equals to crackles, I think. Rales equals to fine crackles. Let's just...
Today's video is going to focus on Rales versus Ronchi. Now, Rales versus Ronchi are very important. And you may be asking yourself, why do I need to know that for step one? And the answer is pretty simple. When you're given questions on step one, they're going to describe the physical exam findings. And if you can interpret those physical exam findings correctly, then it already gives you an image in your head of where the pathology within the question may be anatomically. So after today's video, you'll be able to understand that if they tell you that there are Rales or crackles or Ronchi or wheezing, you'll immediately already begin to form a differential diagnosis, which will help you eliminate incorrect answer choices on your step one exam. So being able to be familiar with Rales versus Ronchi is an anatomy concept. And then you take it a step further and apply it to the pathology within the question. So we're going to talk about the main differences versus Rales versus Ronchi. First, I'll give you the normal, then I'll give you my mnemonic for remembering the difference, and then we'll summarize at the end. So with Rales, it's often used interchangeably with the word crackles. Now, the Rales or the crackles occur at the level of the alveoli. Now, recall that the alveoli are the most distal or terminal portion of the respiratory tree or the respiratory system. So Rales occur at the most distal portion of the respiratory system, the alveoli. Ronchi, on the other hand, are going to be used interchangeably with the word wheezing. Now, Ronchi or wheezing occurs in the large airways or at the level of the bronchus or the bronchi. So again, in summary so far, Rales or crackles occur at alveoli. Ronchi or wheezing occurs at the bronchus. So here is my mnemonic for remembering this major difference. Rales in the tails, Ronchi in the bronchi. This is one of my favorite mnemonics because for the longest time, I had no idea what Rales or Ronchi were. So when I would read a question and it was a pulmonary question in the Q banks, they'd be like, blah, 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 patient presents with this, that, and the other, and crackles are heard at the left lung base, or Ronchi are heard in the right middle lobe, and I'd be like, I have no fucking idea what they're talking about. So I took it upon myself to create this mnemonic, and it's really gone a long way for me. I think it will for you guys as well. So Rales in the tails. Tails refer to like the end, the tail of the respiratory system. So alveoli are the like literally last thing involved in the respiratory tree. So Rales in the tails. Ronchi and the bronchi is just beautiful. It tells you exactly where they are, and it's easy to remember. Now, the one thing that I want to point out that's not on this slide, but will be in the summary, is that Rales are usually due to fluid overload or fluid accumulation. So if you have a pneumonia and you have fluid buildup in the alveoli, or if you have pulmonary edema and you have fluid buildup in the alveoli, you're going to hear those Rales, those crackly noises that kind of sound like you're rolling crumpled up paper in your finger. If you have bronchi, it's typically inflammatory in nature. So people who have an asthma attack have wheezing because there's constriction of the large airways. Maybe there's mucus plugging of the large airways. That's bronchi. So bronchi tends to be more inflammatory, and rails tend to be more fluid related. And if you can just remember rails in the tails, it'll make sense because in this image, if fluid accumulates in the bronchi, it'll probably flow downstream into the alveoli. So when you think of fluid problems, we really think of alveoli as dealing with the brunt of that damage. So once again, rails in the tails, bronchi in the bronchi. So here's my summary slide. Rails are crackly noises. They occur at the level of the alveoli. They are discontinuous because if you've ever heard what the crackling noise sounds like, it's not one continuous sound. It's kind of like, it's a discontinuous, that's a rail. And it's due to fluid overload. A bronchi, on the other hand, is a wheezy type of sound. It occurs at the large airways. Remember, bronchi, the bronchi. It's continuous. So when someone has bronchi, it'll kind of sound like, you hear that each of those bronchi are continuous. And it's inflammatory in nature. It's due to mucus plugging of the large airways and inflammation within the airways. So just remember, guys, rails at the tails, bronchi at the bronchi. From there, you can take it a step further and probably remember all of the other details surrounding rails versus bronchi. And this is huge, huge for you, because if a question tells you that you hear bronchi in the right middle lobe, then all of a sudden you can rule out things that are probably less likely. So you can rule out fluid accumulation at the alveoli and whatever would cause that. And you can start to think of a more inflammatory cause. Maybe this person has asthma. Maybe they're just mucus plugged. You never know, but it's going to help you get to the correct answer much, much faster if you understand the difference and the anatomy. All right, guys, I hope this was helpful. Good luck, stuff.
Very nice. Okay. Rails in the tails, bronchi in the bronchi. So rails is equals to crackles and bronchi is equals to wheeze. It's just different terms. Where did we see the rails bronchi thingy? Here, right? Rails present in the right lower lung. Okay. So maybe there's pneumonia going on. Don't know what can be causing it. Heart tachycardic and regular S1 and S2 auscultated, no S3 or S4, that's normal. Abdomen, soft, non-distended, mild hepatomegaly, 1 to 2 cm below costal margin, and splenomegaly, 2 to 3 cm below costal margin. Generalized diffuse tenderness. Extremities, warm and well perfused, palpable radial dorsalis, pedis, and posterior tibialis pulses, so that's normal. Genital urinary, black urine noted. Neurology is black. Neurology GCS 9. The full is 15, right? 4, 5, 6. Yeah, the full is 15. GCS 9 is low. No focal neurologic deficit, but unable to fully evaluate due to obtundation. Normal deep tendon reflexes of biceps, triceps, patella, and Achilles tendons. Unable to evaluate sensation or gait. Okay. What should be considered in the differential diagnosis? Oh. So you should consider cerebral malaria. The probability of this is high. Reason being, the patient normally lives in an area of low malaria transmission and is traveling to an area of high transmission. High elevation down to the coast. High elevation down to the coast. As an adult with less immunity than those that live in highly endemic areas, he is at high risk of severe malaria from Falciparum, much like travelers from the United States. The Malaria Rapid Diagnostic Test, MRDT, will detect any level of parasitemia, even at low levels, which may not be causing disease. Therefore, even though this is very high on the differential, further studies should be performed, including lumbar puncture, to ensure that no other etiologies exist. Alcohol withdrawal lower. There was no mention about him taking alcohol. No known history of alcohol abuse, but patients can present with seizures and tachycardia, diaphoresis, confusion, and even fever. Once life-threatening etiologies have been ruled out, this diagnosis can be further considered. Acute bacterial meningitis probability is high. Patient does not have signs or symptoms of neck stiffness, but in this setting of obtundation, this physical exam finding is not specific nor sensitive. Lumbar puncture should be performed to eliminate this as a possibility. If patient has Neisseria meningitis, disseminated intravascular coagulation can occur, which could account for the finding of dark-colored urine. Oh, I see. Though not generally Coca-Cola colored urine as seen in this patient. Okay, viral encephalitis, medium risk. This should also be ruled out with lumbar puncture, though in this low resource setting, the ability to treat the patient would be unlikely. Hepatic failure, lower, no jaundice or scleral icterus is present. Liver function tests are pending, but other etiologies are more likely based on this clinical picture. And what's the last option? Organophosphate intoxication, medium risk. Patient is within the high risk age range for suicidal attempts to 35 years old, with organophosphate poisoning. Patients commonly present with cholinergic toxidrome, including constricted pupils, diarrhea, confusion, and urinary incontinence. Cholinergic toxidrome, constricted pupils, diarrhea, confusion, urinary incontinence. Okay. Common causes of death include the killer bees, which are bradycardia, bronchoria, and bronchospasm. Fever is less common, with patients' tachycardia, normal-sized pupils, and lack of hyperactive bowel sounds. This syndrome is less likely. Okay. Lab results. So this white blood count is billions. Is it the... Why don't you give me the normal range? Normal range is 4 to 11, right? I'm not sure about the units, but the unit that I remember, the normal range is 4 to 11. So this is normal. Hemoglobin is low. Platelets is low. Normal is 150 to 400. BUN. What's a normal BUN? 7 to 20 mg per deciliters is high. Creatinine. What unit is this? Why is it so low? Creatinine, normal range. Milligrams per deciliter. I think this is the unit they are using. Okay. Normal should be 0.48 to 1.21. This is high then. High BUN, high creatinine. Indicating AKI. Acute kidney injury is happening. Platelets is low. Hemoglobin is low. Hemolysis. Is there a degree of hemolysis here? Is there a degree of DIC here, causing platelets to be low? DIC platelets will be much lower though. Okay, next. What are the most appropriate next steps in diagnosis and management of this patient? So previously mentioned, he needs a lumbar puncture to rule out bacterial meningitis. You want a malaria rapid diagnostic test as well. Blood glucose. Since DKA was part of my differentials, I would choose to do a blood glucose simply because it's quite easy to just do a finger prick and then measure his blood glucose, and you can straight away rule in or rule out DKA. But it wasn't mentioned in the discussion of the differentials. Anyway, blood glucose is something you should do in meningitis when you're investigating for meningitis, because you want to compare the blood glucose and the CSF glucose to gauge, to interpret the CSF. Blood cultures, are we suspecting sepsis? In this case, probably not yet. His blood pressure is normal. Heart rate, respiratory rate is high. Anyway, we can do this later. Chest x-ray. Should we do a chest x-ray on him? Oh yes, there is some bronchi, right? No, there were some rails in the tails. So I want to see whether he has pneumonia or not. Blood smear, what would this show? Is it important in malaria as well? Blood smear? Blood smear you can see in malaria, right? Okay. Let's see. Incorrect. You did not select the correct response. The correct answers are lumbar puncture, blood cultures, and blood glucose. Oh? Why? So now you're not suspecting malaria anymore? Why are you not suspecting malaria anymore? Can I go back? Let's see why you're not suspecting malaria anymore. Why are you not suspecting malaria? High risk. Lab results. White cell count normal. I don't understand why. Lumbar puncture, blood culture, blood glucose. What are the most appropriate next steps in diagnosis and management of? Well, okay, let's see their explanation. Chest X-ray. Ensure there is no lung pathology accounting for the patient's tachypnea and hypoxia. MRDT, malaria blood smear. Malaria is high on differential due to anemia, thrombocytopenia, convulsions, cerebral malaria, hepatosplenomegaly, and dark-colored urine. Lumbar puncture, all patients should receive to rule out bacterial meningitis. Blood cultures, no explanation. Blood glucose check, no explanation. Oh, the explanation is up here. Sepsis can present very similarly with tachycardia, tachypnea, and multi-organ failure. Sepsis can present very similarly with tachycardia, tachypnea, and multi-organ failure. Okay, blood cultures. You are suspecting sepsis here. Blood glucose. Assess for hypoglycemia and treat if patients treat present with dextrose 50%. I think this thing is outdated. So the current guidelines say that you should give dextrose 20%, not 50%. With dextrose 50% is too concentrated and there's a risk of causing thrombophlebitis. Okay. So there must have been an error on the previous answer checking mechanism then. Because over here they say you need to do malaria, you need to do chest x-ray, you need to do lumbar puncture. I think blood cultures was the one that I didn't do, which I should do. Anyway, correct answers: lumbar puncture, blood cultures, blood glucose. Anyway, next. Oh, is this his chest x-ray? Right side consolidation, left side also some patchy consolidation. It's like pneumonia. Lab results: lumbar puncture, opening pressure. What's the normal opening pressure of a lumbar puncture? (10 to 20 cm). (31 is raised, I guess. Should give me the normal values. Glucose. I don't use these units. 70. Glucose number. Let me see CSF. Where? Okay. Let's see. Opening pressure. There's no opening pressure here, but I assume it's high. Glucose 72 mg per dl. Glucose normal is 40 to 80 mg per dl. Protein 35 mg per dl. Protein 15 to 60 mg per dl. So everything is normal so far except for the pressure. White blood count 4 cells per high power film. Cell count, right? 0 to 5 lymphocytes per microliter. White blood cell per high power film. Normal range would be so much easier if they included the normal range. Normal white blood cell count is between 0 and 5. Okay, I'll take this one. So it's normal. Everything is normal except for opening pressure. Let me check the opening pressure again. (16 to 25 cmH2O). mmHg. What is it in mmHg though? What's this unit? What unit are you using? Opening pressure. What unit is this? Where's this? (8 to 15 mmHg). So this is raised opening pressure, the rest is all normal. Okay. Diagnosis based upon the previous labs and clinical presentation. The patient was diagnosed and treated for severe malaria. Click for definition. Malaria is a systemic infection of erythrocytes by Plasmodium protozoa transmitted to humans through bites of infected Anopheles mosquitoes. What is the appropriate first-line treatment plan for this patient? I think artesunate is the first line. Wait. Is it artemisinin or artesunate? They sound the same. Can't remember. Artemeter doesn't sound right. It's artesunate, I think. Quinine is one of the second line. Let's see. Incorrect. You did not select the correct response. The correct answers are IV, artesunate, and admissions to intensive care. Oh. Okay. I might go back and see. Never mind. After treatment of severe falciparum, after confirmation of diagnosis, full doses of parenteral anti-malarial treatment should be started with first available effective anti-malarial agent. IV artesunate is preferred agent. Reduce mortality in adults and children compared to quinine based on the Lancet. Give artemether or quinine only if artesunate is not available. Give until patient is able to tolerate oral medication. Then complete therapy with artemisinin-based combination therapy, artesunate plus clindamycin or doxycycline, quinine plus clindamycin and doxycycline. Let me see my answer, please. That's annoying. Not very good user interface. Where's the admissions? Can't move this, can I? Can't click back. Can't click anything else. Next. Yeah, I'm stuck in the screen. I can't see the options anymore. Anyway. Let's look at what is artesunate. What is artemisinin? No, it's not in the EMC, huh? Oh, it is. Yeah. Reamet. Arthimeter. I think this is a bit different. I think this is a little bit different. What am I looking for? Pharmacodynamics. Okay. Antimalarials. Reamet comprises fixed ratio 1:6 ratio parts of artemether and lumefantrine. I think it is something different. Medscapes. Okay. Just go to pharmacology and need to click the refresh button. Here, mechanism of action. Artemisinin derivative. Artemisinin-based combination therapy. Artesunate. Dihydro. Artemisinin derivative rapidly metabolized to active metabolite dihydroartemisinin. Artesunate and dihydroartemisinin, like other artemisinins, contain an endoperoxide bridge that is activated by heme iron, leading to oxidative stress. Inhibition of protein and nucleic acid synthesis, ultrastructural changes, and decreased parasite growth and survival. Artesunate and DHA are active against the blood stage asexual parasites and gametocytes. Okay. Artesunate. Initial treatment of severe malaria. Vivax or Ovale. It's only for Falciparum then. Artesunate and DHA exposure response relationship and their time course pharmacodynamic responses are unknown. Unknown. Okay, that's not very informative. Never mind. Artesunate versus artemisinin. Artesunate represents a semi-synthetic derivative of artemisinin that has improved water solubility. Okay. Okay then. It's the same thing, it's just an alternate form of it. Alternative form of it. Okay. Management of cerebral malaria require meticulous nursing care and admission to intensive care or high dependency unit if available. Assess airway breathing and circulation (ABCs). Close monitoring of vitals, urine output, and airway protection. Attain good IV access. Treat hypoglycemia if present. A rapid treatment of benzodiazepines for convulsions. If patient continuing to have despite 2 doses of diazepam, should be considered to have status epilepticus and given phenytoin loading dose followed by daily maintenance dosing. Avoid medications for increased intracranial pressure such as mannitol or hypertonic saline as they have not shown benefit. Avoid corticosteroids. DT, worse outcomes. Found to be increased gastrointestinal bleeding and seizures. The English here is not very good. Avoid corticosteroids. And what does DT stand for? Not helpful. Short forms not helpful. Found to be increased gastrointestinal bleeding. Oh, okay. Corticosteroids increase GI bleeding and seizures. Okay. What is severe malaria? See answer. Severe multi-system disease with high risk of death. Okay. Which features of severe malaria did this patient have? Which features of severe malaria? So it's multi-organ failure, right? Renal failure, I remember is creatinine is raised, urea also raised. Hypoglycemia, was it measured? They definitely didn't give me the result. Or did I miss it just now? Did he have shock? No. Did he have bleeding? No. Did he have respiratory distress? Yes. Black water fever. I think he's talking about the urine and his fever for 3 days. Severe anemia. His anemia was 9 point some. His HP was 9 point something. Not that severe yet. Normal is above 13 point something. I guess you can say that's anemia. Cerebral malaria. What definitions? Oh, there are definitions here. Okay. Severe normocytic anemia, defined by a hematocrit of less than 15% or hemoglobin less than 5 in the presence of parasitemia. So it doesn't have severe anemia. Okay. Cerebral malaria, complication with most fatality, 20% of those treated, seen in non-immune adults and children, defined as coma in the setting of parasitemia when other causes of encephalopathy have been excluded. Does he have coma? It's not. Yeah, he is obtunded, so coma, I guess. Respiratory distress, rapid labored breathing can be due to acute respiratory distress syndrome, parasites and neutrophils cause direct alveolar capillary damage, lung infection such as pneumonia due to immunosuppression. This is what he's having, given the crackles that we hear. Respiratory compensation for metabolic acidosis. I think that's the Kussmaul's breathing that is talking about. Air hunger from anemia. Hypoglycemia caused by impaired liver function can be due to quinine-induced hyperinsulinemia, all presenting with coma or convulsions, especially young children, should be screened for hypoglycemia. Shock, also called algid malaria. Circulatory collapse, DT malaria. What is DT? T. Delirium tremens? I don't think so. Due to, can't type a due to, huh? Circulatory collapse due to malaria that manifest with systolic blood pressure less than 70, cold clammy skin, and steady rapid pulse. DIC, due to pathological activation of the coagulation cascade. Patients presenting with findings of consumptive coagulopathy with thrombocytopenia, bleeding, diastasis, and spontaneous bleeding, and microangiopathy of the neurological deficits, confusion, and/or renal failure. Blood smear demonstrates cystocytes and parasitemia, increased prothrombin time (INR), and decreased fibrinogen. Renal failure, increased creatinine more than 3, increased urea and decreased urine output, pre-renal, renal in etiology, black water fever, massive hemoglobinuria, often precipitated by treatment with oxidative drugs such as primaquine or quinine, more common in those with G6PD. Okay, this is glomerulus. Why are you showing me a glomerulus when you're talking about black water fever? Show me a dark urine. Okay, so he does not have severe anemia because it's supposed to be less than 5. That's right, you selected the correct response. Continue. Criteria for severe malaria, clinical manifestations, laboratory tests. Okay, clinical manifestations, you need to have prostration. What's prostration? It's you just lie down flat without moving, right? I think I've searched for it before. Prostration, the action of lying stretched out on the ground. Weak, subservient, extreme physical weakness or emotional exhaustion. Impaired consciousness, respiratory distress, multiple convulsions, circulatory collapse, pulmonary edema on X-ray, abnormal bleeding, jaundice, hemoglobinuria, black water fever. Laboratory tests, severe anemia, hypoglycemia, acidosis, renal impairment, failure, lactic acidosis, hyperparasitemia. Okay. That's the end of the interactive session. Hope you enjoyed it. Thanks for watching. Bye bye.